Hello, I'm Matthew Weinstock with Hospitals and Health Networks. Rural hospital leaders are wrestling with the question of how they can stay independent in the face of so much change that's taking place in the field. For some hospitals, affiliation seems to be a solution for being able to continue to provide valuable services for their communities. I'm joined right now by Jeanine Gentry, CEO of Pioneer Memorial Hospital in St. Charles, Madras, to talk about how they've taken an approach to affiliation. Jeannie, thanks for being with me today.
Thank you for having me.
So let's start off, can you give me a little bit of demographic background on your hospital and your location and where you are?
I lead two hospitals right now. Both of them are in service areas of about 20,000 people in two different counties, 30 miles apart. And both of them are rural and very proud of their local hospitals.
Talk to me a little bit about how rural hospitals are positioned to deal with population health and what you've seen with your communities.
So in both of my communities, we have urgent needs for improving the health of the community. And in both of these two communities in the last 5 years, we've chosen to do different affiliation models with a nearby larger health system. Part of the reason for that is that our patients don't just stay at home for their health care. They also go to the larger facilities especially for their specialty care. And so it behooves us to cooperate in many ways with the other hospitals in our region to provide better health care for those populations.
What went into those discussions and decisions to decide to affiliate? Walk me through how you went through that with your staff, with the boards even.
Well, the boards realized that we were coming up to a perfect storm, if you will. Financially, the pressures were mounting. We needed more capital to improve our facilities and our electronic health records. We had less reimbursement, and Oregon particularly was expanding Medicaid, which was a large portion of our payer mix. So as we talked with the board about different options, affiliation seemed to be the best option for the community to keep a hospital thriving and not just alive.
And why affiliation versus a merger or consolidation?
Well, the affiliation model was done in Prineville as kind of a long-term operating lease, but the board retained the facility and some amount of directive authority over the hospital. In Madras, we went ahead and did a full merger and transferred the assets of the hospital to the larger system. So we kind of got to see both sides of a relationship there, and both ways have worked out well for us.
And I guess as you're weighing those affiliation and a merger, how do you decide which approach is best for the hospital?
It really depends on how much is needed and what the partner is willing to give at various stages of affiliation. Loose affiliations like maybe a management agreement or group purchasing options don't bring in the kind of capital investment that we needed in our communities. And so the further options of merger and tighter affiliation were really necessary in our cases.
And as you look at what it does to the culture of your organization when you go through an affiliation model, walk me through what that's been like for you. I imagine you have maybe different quality committees from one organization to the other. So how do you manage that process?
Well, it's been step by step, really, and it is difficult. We had many community meetings before the transitions happened. We had many meetings with our caregivers and with our medical staffs. And some things transitioned immediately. Some things are still transitioning 2 years after the merger in Madras took place. But we had a long list of things that we needed to combine, and we have taken it step by step through the process of combining and streamlining, really.
The goal, obviously, is to continue to provide those valuable services for your patient population. So yes. What have patients seen from these new relationships that you've had?
Well, we've been able to recruit more physicians to our communities because of the improved access to recruiting and financial resources, honestly. And so our patients have more access to primary care than they were able to get when we were on our own. We're also able to provide some of the latest technology that we weren't able to provide in terms of imaging technology, electronic medical record technology, and sharing of information.
And I guess lastly, how does this position you to move towards more of a value-based reimbursement model?
Well, there are many decisions that I couldn't make on my own as a private hospital, for group purchasing, for many of the service line distribution questions. I joked that I would have given away my firstborn for an orthopedic surgeon before, but really an orthopedic surgeon doing hip replacements in our little hospitals wasn't appropriate. Now I'm free to really look at what is the best impact for close to home versus what things really are okay to have a person travel for, to go far away for that once-in-a-lifetime hip replacement. So it really has helped us to make the right decision for our patients, not just the right decision for our bottom line.
Okay, I appreciate you taking some time to talk about what you've been doing at your hospitals.
Yeah, thank you very much.
And I'm Matthew Weinstock with Hospitals and Health Networks. Thanks for tuning in.